taking the focus from vessels to the liver lobule proper, I will be discussing histopathological grading of MAFLD. This is a brief outline of my talk. I will intend to cover from role of histology in MAFLD and its evolution of histopathological grading, right from beginning to what we know till now, and a little bit of about pediatric NASH as to how different it is from the typical adult NASH when it comes to histology. So MAFLD, we all know that was formerly known as NASH, and by definition it requires demonstration of steatosis either by imaging or by liver histology. So apart from demonstration of steatosis, the liver biopsy role comes into play when there is an uncertainty about the diagnosis, when we are not sure that what we are dealing with is actually NASH or not, or when we are suspecting an overlap with some other disease like an autoimmune, or when there are atypical clinical tests, like we encounter undue elevations in transaminases, which cannot be explained just by presence of NASH. When there is a non-concordance in the non-invasive test, when the non-invasive test fibrosis does not match with the fibrosis as given by imaging. Also, these patients are usually having gallstones and are obese. So at the time of a bariatric surgery or a cholecystectomy, an open intraoperative biopsies can be done. So the first attempt towards grading of NASH came from Brunt in the year of 1999, and they defined the minimum histological requirement of more than 5% of steatosis for a diagnosis of MAFLD. So this is the basic grading proposed by Brunt, and it covers steatosis, inflammation, ballooning and fibrosis. The most important points to note in this grading was that they did not differentiate between a score 0 and a score 1 steatosis. Any steatosis up to 33% was put as score 1 steatosis or mild steatosis. They included portal inflammation along with lobular inflammation within the score, and also the fibrosis was just categorized into perisinusoidal plus periportal, bridging and cirrhosis. So then came up the NAFLD activity score by the NAS-CRN group, and multiple centers under the Clinical Research Network participated in this scoring system or its validation. They addressed some of the problems of the Brunt scoring system, and they differentiated between the score 0 and score 1 steatosis. So score 1 steatosis was defined between 5 to 33%, and they considered only lobular inflammation. They did not include portal inflammation as described initially by Brunt in their scoring system. Ballooning was scored as few or many. So cumulative total score can range between 0 to 8. Less than 2 is definitely not NASH, more than 5 it gets into definite NASH, and when we are dealing with a borderline score of 3 to 4, the case cohort was divided evenly between all the 3 diagnostic categories of NASH. Fibrosis, they further subdivided the stage 1 fibrosis of the initial Brunt category. So any mild perisinusoidal fibrosis which requires a connective tissue stain for its demonstration was put as 1A. Any moderate fibrosis was put into 1B, and when the fibrosis is only periportal without perisinusoidal, it was put as 1C. Rest of the categories remained the same. So this scoring system is very easy to understand. It is still by far the most widely applicable system used for diagnostic and therapeutic trial purposes, because it clearly separates the 3 lesions that comprise the grade, and but still this system has its own disadvantages. The first and foremost is inclusion of steatosis in the activity score, because just plain steatosis does not correlate well with the disease activity, and they have also not included fibrosis in the activity score, which can lead to missing of significant liver diseases, significant fatty liver disease in case of burnt out diseases. So this was a major study which got published in 2019 by the Kleiner group, and they correlated this NAS-CRN score with the progression of non-alcoholic fatty liver disease. So as we can see, when the disease status improved from improvised, the disease profile improved either from NASH to NAFL or borderline to NAFL, there was an improvement in the stage of fibrosis. These darker greens, they represent score 0 and 1 fibrosis. So definitely there is an improvement in the stage of fibrosis. And when the disease status deteriorated, either from NAFL to NASH or borderline to NASH, Or another case scenario, that lower stages of fibrosis have reduced and there is an increase in the higher stages of fibrosis. The same is reflected in this graph, with a positive increase in the NAS score leads to an increase in the stage of fibrosis. So resolution of steatohepatitis scores is always associated with bettering of the transaminases and the stage of fibrosis and BMI levels also. So these are the few case scenarios that we commonly encounter in the lab. How do we implement these grading and scoring systems into the routine pathology practice? So as you can see in this liver core, these are the large steatotic vacuoles and they are easily occupying almost 70% of the hepatic parenchyma that is evident in this corner. So definitely going by the NAS scoring system, this is a grade 3 steatosis. Now coming to this picture, this is a high power of the same biopsy. Now these pale balloon cells are seen over here, which have lost their polygonal shape. In between these are the normal hepatocytes, which are polygonal with their eosinophilic granular cytoplasm. In comparison to these cells are definitely swollen, ballooned with pale rarefied cytoplasm and have become rounded. So these are the ballooned hepatocytes and we can see so many of them scattered over here with few foci of lobular inflammation. So for ballooning, this can be definitely put as a category 2, score 2 ballooning. And if we calculate over the biopsy, the lobular inflammation score was calculated over as 2. So the cumulative score came as NAS score of 7. Now coming to the Mason trichrome stain section, this is a portal tract which is expanded with periportal extensions and formation of a bridge. So this is a bridging fibrosis. So the fibrosis score was put as 3. This is another case. Now in comparison to the earlier case, we can see that the steatosis is very limited in this biopsy. This is a portal tract, this is another portal tract. Probably this represents a zone 3. And definitely the amount of steatosis is more than 5%, but it is less than 1/3 of the liver parenchyma that we see over here. So this is a score 1 steatosis. Now coming to the high power, again these are few ballooned out hepatocytes which are pale, rounded in shape with rarefied cytoplasm with a focus of lobular inflammation. So this score can be given as 111 for ballooning steatosis and inflammation, lobular inflammation as a score 3. And then coming to the empty stain, the portal tract is very much normal with no increase in the portal fibrosis and some little bit of perisinusoidal fibrosis is seen over here, which definitely requires to be demonstrated in an empty stain section. So the fibrosis score is 1A in this biopsy. Next was the steatosis activity fibrosis score. The rationale behind this score, it came out in 2012. The rationale behind this score was that the lobular activity is what differentiates a NASH from NAFLD. So definitely lobular activity score and presence of steatohepatitis are interrelated to each other. And also, as we saw in the earlier NASH scoring system, there is a grey zone of score 3 to 4 where the steatohepatitis can be present or absent. So definitely it requires the evidence through another scoring system which can put a definite category of NASH in these cases. So the activity score in this system, SCAF scoring system, is calculated by cumulative scores of ballooning and lobular inflammation. Under the category of ballooning, more reference was given to the size and shape of the hepatocyte in comparison to the earlier systems. Score 0 is a normal hepatocyte. Score 1 is the presence of clusters of hepatocytes which are almost similar in size to that of a normal hepatocyte or maybe slightly bigger, but they have become rounder, pale with rarefied cytoplasm. And a score 2 ballooning is called when the size is almost 2 times the size of a normal hepatocyte. Lobular inflammation in this was scored as 0 to 2 and fibrosis and steatosis scores were similar. So this is another biopsy. These circles, if we focus on, these are the ballooned hepatocytes which have become rounded and pale and lost their polygonal shape. But the size, if we can compare to the normal hepatocyte, is almost similar or maybe slightly bigger, all these over here. In comparison to this, if we look at this arrow, so this ballooned hepatocyte is definitely almost reaching twice the size of a normal hepatocyte. So going by the SAF scoring system, all these circles represent a score 1 ballooning, while this arrow will represent a score 2 ballooning in the same case. So in the same paper, Bedosa et al. They demonstrated the correlation of the activity with the presence of NASH. So if a activity score of more than equal to 2 is taken into account, over 90% of the cases were put into the category of definite NASH. In comparison to the NASH system, where we can see there is a lot of overlap in the score of 3 to 4 between not NASH and definite NASH. Also, when we correlate the activity score with the transaminase levels, increasing rates of activity is associated with increasing level of transaminases. So the activity score correlates well with the presence of the diagnosis of NASH and also with the transaminase levels. Based on the SAF score, flip algorithm came into play, which is the fatty liver inhibition of progression algorithm. To enter into this algorithm, at least minimum score 1 status is required. After that, if ballooning or lobular inflammation, both of them if they score 1, so basically any of the parameters, all of these parameters, if they are at least score 1, the case can be put as steatohepatitis, and if any of these parameters, ballooning or lobular inflammation is 0 or it is absent or minimal, this case still being diagnosed as just as fatty liver. So this is another very big study from our center only, ILBS, and in this study there was a case database of over 1000 of cases, and both the morphological scoring systems were compared in their efficacy for prediction and diagnosing NASH and correlation with the clinical profile of the patient. So it was observed that there was an excellent concordance for definite NASH and not NASH categories between both the scoring systems. It was also noted that 88% of borderline NASH cases, which were classified as borderline on the NASH scoring system, were picked up as definite NASH by SAF system, emphasizing the value of SAF system in the cases where the borderline scores are seen of 3 to 4. Also, they observed that higher rates of steatosis, ballooning and lobular inflammation along with higher fibrosis stages and higher transaminase levels were seen in cases of NASH. It was also observed that burnt out cirrhosis led to lower NASH scores because in these cases the minimal steatosis would be less than 5% and hence it will not lead to them being categorized into definite NASH category, and they were falsely categorized into not NASH basket, highlighting the need of inclusion of fibrosis in these composite scores. This is another study which covered validation of flip algorithm and SAF score. It was published on the behalf of EASL in 2020. In this, 140 consecutive patients with suspected MAFLD and a separate validation cohort of 78 patients who were enrolled in different therapeutic trials were assessed. So in this study, the increasing level of the disease activity as scored by the SAF parameters was associated with increasing BMI levels in both the cohorts, also with increasing insulin resistance in both the cohorts, and along with severe activity was associated with higher level of transaminases in both the cohorts, implying that the disease activity correlates well with increasing BMI, insulin resistance levels, transaminases and fibrosis in the patients. So this system, SAF system, is advantageous over other systems that any degree of ballooning and lobular inflammation, if present, it leads to a diagnosis of NASH, which was a lacuna observed in the NASH-CRN system, because of which many of the borderline cases were put into not NASH category. And but the disadvantage, as we see with other systems, that it does not include fibrosis staging, while calculating the score for predicting NASH continues with this system also. These guidelines came up recently on behalf of ASLD. These are the guidelines for reporting histopathological findings in clinical practice. This was published in 2021. And they have maintained the essence of the initial Brunt grading. In terms of, they have graded NASH as steatosis, inflammation, ballooning and fibrosis. A few important things to note in this system where the improvisations over Brunt system can be seen are that in the portal inflammation, they have included the portal and lobular inflammation both, as was in the initial system. In the portal inflammation, moderate inflammation is called for when there are at least 2 portal areas involved, and marked portal inflammation is scored when there are multiple portal areas involved with a spillover into an adjacent hepatic parenchyma. Also, they have given more objectivity to the assessment of ballooning in terms of its extent, that when balloon cells are present in less than half of the zone 3 areas, it is put into mild or few balloon cells, and when the balloon cells are seen in more than half of the zone 3 areas, it is called as prominent, many, or marked ballooning. So the final reporting recommendations by this group is that the final diagnostic line in the report should include both pattern of injury and severity of the features. If the etiology is known from the clinical history, it should be definitely added in the report. If there is a dual pathology, it can also be added to the report if there is a supporting history. Though they have included portal inflammation, they have acknowledged that globular inflammation is the only inflammation component added to the composite scores such as NASH or the SAF system. The scoring reference should always be cited. The steatosis, this is important for us as pathologists, that the steatosis should always be assessed at the scanner magnification at 4x. And though they have given importance to presence of spillover as a grade 3 portal inflammation, severe interface activity, whenever we see in a slide, we should definitely look for other causes. In 2020, these were the guidelines published on behalf of APASL, where we saw a shift in nomenclature from NASH to MAFLD to make it a diagnosis of inclusion rather than a diagnosis of exclusion. So in these guidelines, they have recommended certain features for MAFLD related cirrhosis in case scenarios where we see a cirrhosis in a biopsy with absence of typical histology of MAFLD, like if we are not seeing enough steatosis to be attributed to MAFLD, we can still call it a MAFLD related cirrhosis. If there is an earlier biopsy suggestive of MAFLD, or there is a past documentation of steatosis by imaging. So for a case scenario like this is an empty stain, and we can very much see this is a case of cirrhosis with this micronodule and broad intervening fibrosepta, which are separating the nodule from the rest of the parenchyma. This is the same field in H&E stain, hardly any steatosis over there in this field. Another field in the same biopsy, few steatotic vacuoles, like few are seen over here and maybe few over here also. So definitely this is not qualifying up to 5% steatosis. So if we go by definition, we cannot call it associated with NASH or because of MAFLD. So in these scenarios, these recommendations come into play, that if there is a prior biopsy documentation of MAFLD or demonstration of steatosis by imaging, such cases can still be called due to MAFLD. So coming to pediatric NASH has a little bit different morphology from a typical adult NASH. These were the guidelines from North American Society of Pediatric Gastroenterology and Hepatology. So pertinent to histopathology, they have few recommendations that a biopsy in a pediatric NASH should be 2 cm long. This is to accommodate the heterogeneous nature of the disease in comparison to the adult NASH, where it is usually recommended 1.5 to 1.6 centimeter. Also, pediatric NASH, especially in very young children, more often there is a zone 1 steatosis. Portal and lobular inflammation both can be very mild. Ballooning can be minimal to mild, and even if ballooning is present, it might be of non-classical type, where the ballooned hepatocytes are almost of the similar size of that of a normal hepatocyte. So by definition, if ballooning is absent, it will not be classified as steatohepatitis, but still this paper recommends that extent of steatosis, inflammation and fibrosis needs to be documented, and we need to remember that the NAS scores may not correctly estimate the extent of steatohepatitis in these kind of pediatric NASH cases, and the fibrosis may be portal dominant rather than a zone 3 dominant phenomena. Similar findings were observed by this Columbia University group. They were published in 2020, and they observed similar findings in children with more of a zone 1 dominant pathology rather than a zone 3 dominant pathology in cases of pediatric NASH. In case of pediatric NASH, we can see the extent of macrovesicular steatosis occupying the entire length of the biopsy that we see in this field. Now, high power view of this same biopsy hardly any ballooning present over here. It is just the steatosis, very minimal portal. This is crushed portal tract at the edge, and very negligent lobular inflammation. So this is more very pauzy. They can be, just to remind that despite of so much of steatosis, the biopsy can be very pauzy inflammatory and pauzy ballooning in look. This is another study from ILBS, by far the largest case database that I could find out in the literature. It covers around over 1200 biopsies of NAFLD, of which around 21% were of lean NASH cases. So there were few differences, so I thought that I should probably mention it over here, which we observe in lean NASH cases. Ballooning and steatosis, they are more marked in lean NASH cases in comparison to typical NASH groups. And also lobular inflammation and advanced fibrosis, they were in comparison less in comparison to the typical obese NASH related patients. So to conclude, these are the pathological reporting guidelines which as a pathologist we should remember while reporting for MAFLD. Always standardized reporting for MAFLD is recommended, and it is very important for both diagnostic and therapeutic trial purposes. The minimum set of slides that one requires for a diagnosis of MAFLD is a routine H&E stain and a connective tissue stain, Mason's tricone for routine reporting, serious red when we employ morphometry, when we intend to do morphometry on the slides, flip algorithm and SAF scores, or a NAS-CRN score. At least either of them should be used for standardized reporting. Dwell pathology, if identifiable, should always be reported and put in the final line of the diagnosis. Thank you.